Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemreg.
And let's get started on today's topic.
From basics
to brilliance. Hi David.
Hello.
Nice to see you again.
Yes, lovely to be back.
Yeah.
Very excited for some more haematology action.
Exactly. It's been a while, hasn't it, with summer holidays?
It feels like it.
Yeah.
If my brain's slow and stupid, I'll blame the time.
So, we are moving on to all of the very exciting clinical stuff in haematology now, and none less than Haemophilia A today.
You look a little bit too giddy. I don't know if this is a bit of an ominous sign that
No,
about to
it's
get
great. No, clinical
wrapped
stuff
up.
is even more exciting than the lab stuff we've already covered.
Okay.
But it's a big topic, so I think we'll need to divide it into multiple podcasts to make it easier to listen to and more bite-sized. So today we're just going to cover diagnosis, presentation and investigation. So that initial stage of somebody getting a diagnosis of haemophilia A. And we're not going to do anything to do with management. We'll save that for next time.
Grand.
Great. Okay, so let's just start with an open question. What is haemophilia A? What do you know about it? And then we'll start from there and build up.
Yeah, well, good. Thank you for letting me get a word in, because I highly suspect that this is going to be my only chance to shine.
Don't always put yourself down.
So I think, the thing that we all learn from medical school is it's X-linked recessive, so mainly affects males.
Okay.
I do admit I had a little look. About 25 people in 100,000 in the UK. It's about the number I found.
Okay.
And from what I understand, it's sort of a deficiency or dysfunction in Factor VIII.
Very good.
And then the sort of severity can come in a range depending on how well your Factor VIII works or whether it's completely defunct.
Yeah, good. Okay, that's a really good synopsis. So it's an inherited X-linked bleeding disorder due to low levels of Factor VIII. I think before we talk any further about haemophilia A, we probably need to just remind ourselves of the pathogenesis of it and kind of just talk a bit about Factor VIII as a molecule. So do you know where Factor VIII is produced?
So I imagine it's a liver.
Yeah, so it's made in the liver, but it's also made in the spleen and in the lymph nodes. I don't know by how much. I suspect it's mainly liver. But also some Factor VIII is made in endothelial cells, so particularly those in the lung, for example, and that's what provides us with the desmopressin releasable pool of Factor VIII that we utilise to our advantage when we talk about management later on using DDAVP. So it's made in the liver, but also the spleen, lymph nodes, and also some is made in endothelial cells.
Nice.
And can you remind our listeners as to how Factor VIII is important in the formation of, a secondary hemostatic plug?
Yes, so it's part of the coagulation cascade. On activation, Factor VIII, which is a cofactor for Factor IX, helps activate Factor X, and it gives us our thrombin sort of process, which leads to our fibrin clot.
Lovely.
So it's a cofactor in
very good.
the process.
Yeah, exactly. And what you've described there really nicely is the sort of intrinsic clotting pathway. So that pathway that's typically measured by our lab tests using the APTT. However, remember we also discussed how this linear kind of division between extrinsic and intrinsic clotting pathways is not really a true representation of how clotting looks in real life. And probably and the reason why that's particularly relevant for understanding haemophilia A here is If it's just an intrinsic factor problem by having no factor VIII for that intrinsic pathway, then why do haemophilia A patients have a bleeding problem? Because couldn't they just ramp up their extrinsic pathway? Couldn't they just compensate by making more factor VII and then doing factor VII tissue factor and then going down the common pathway? So
Yeah, good point.
yeah,
That's
and that's
the
something.
logical next question, isn't it?
Exactly. And that was something that really bothered me for ages, in my understanding of haemophilia A. Is like, well, why can't the body just compensate? And
Yeah.
why does it produce such a profound bleeding disorder when it's severe? And the reason is because um, actually it doesn't exist as two separate pathways that converge on the common pathway. What actually happens is you get an initial priming production of thrombin, whereby you get your traditional extrinsic pathway, so your tissue factor and your factor VII, which combine together to then go down the common pathway and make an initial bit of thrombin. And then it's that initial bit of thrombin that then has a positive feedback loop on making the production of factor VIII and factor IX activation, which then allows factor VIII and factor IX to bind with factor Xa and make the 10As complex, which is this big floating raft of like 8, 9, and 10. And that then allows a massive amplification of thrombin production. So it's not two pathways separate. It's actually kind of the extrinsic pathway first, if you like, but it makes a little bit of thrombin. And then that thrombin has really important positive feedback loops to activate factor VIII, factor IX, and the formation of the 10As complex, allowing essentially this thrombin burst through this massive positive feedback propagation phase. And so that's why in haemophilia A, if you don't have enough factor VIII, you can't just compensate because you just don't get that massive positive feedback.
Yeah, the amplification is the key then. So,
Yeah.
and without that bit of feedback, with that
Yeah,
extra push, it's just going to do very little.
exactly. Yeah.
That's a really a good concept to sort of, I guess, ingrain in your brain, isn't it?
Yeah, yeah. It really, I was like, oh, finally, like clotting makes sense. And it's because the intrinsic and extrinsic pathways and that separation is really useful for thinking about the lab test, the PT and the APTT, but it's a completely artificial construct, really.
Yeah.
So, yeah, great. So then talking about the structure of factor VIII, I wouldn't expect you to know anything about the structure of factor VIII.
Oh, thank goodness, because
Yeah.
you're about to be disappointed.
Okay, I'll just witter on then. So,
Hey, you go ahead and I'll smile and nod.
okay, great. So, factor VIII is essentially a protein, about 300 kilodaltons, and it consists of a heavy chain and a light chain. And the heavy chain is made of an A1, A2, and a B subunit. And the light chain is made of an A3, C1, C2 subunit. And the two chains, the heavy and light chain, are linked together by a metal ion. A bit like antibodies, the way they have a heavy and a light chain, sort of similar concept. Um, and I guess the thing to say is that the A domains, A1, A2, A3, are 30% homologous to each other. And we think that is why we are prone to getting mutations in the factor VIII gene, is because there's so much sequence identicalness, if that's such a word, between A1, A2, A3 subunits. And we'll come back to that. And then the B subunit is the thing that is essentially, it's a variable region on the heavy chain, and it's cleaved off by thrombin. And that's what causes factor VIII to go from its inactive form to its active form, the factor, VIIIa.
Yeah.
So that's the B subunit, which needs to be cleaved off to make it activated. And then the C1 and C2 domains are the area of factor VIII that's important for binding to a molecule that it circulates with in the blood. Do you know what that molecule is?
I'm hoping it's von Willebrand.
Yeah, very good. It is. And so
Is that your test just to make sure I'm still listening?
that is, yeah, it's just to make sure
Throw
you're
him a
not
bone.
falling asleep. So greater than 90% of factor VIII circulates complex to von Willebrand factor, and that prolongs its half-life. And we can see the effect that that has in some of the von Willebrand conditions, whereby the binding of von Willebrand to factor VIII is impaired, and you do get a sort of a mild haemophilia A picture as well, just because you lose both von Willebrand potentially, but also your factor VIII level. So that's the von Willebrand type 2N, which we'll do all about von Willebrands another time. But okay, good. So that's the structure of factor VIII. So you're off
just for our listeners' sake, I guess I guess my future sake as well.
Mm.
How important do you think it is to know the structures of something like factor VIII for, I guess, for I don't know, day-to-day hematology life and for exam purposes.
I think it's mainly for exam purposes, if I'm honest.
Okay.
But it is nice, even for day-to-day life, to understand what you're thinking about at a deeper level and kind of understand, if you think about the structure of factor VIII, you're not going to forget that firstly it needs to be cleaved by thrombin to remove that B subunit. And also you're going to think about, okay, if I've got somebody I think might have haemophilia A, I need to make sure that I definitely rule out von Willebrand's disease as a really important differential. So because we know that, they bind together and they go around together. So yeah.
I guess having a structure to function thing is probably
Yeah, exactly.
okay.
Yeah, and it's fair game in the exams. So if you want to be a hematologist long term,
yeah, there's no avoiding
there's
it.
always that. Okay, right. So you've already given us a bit of epidemiology, and haemophilia A affects 1 in 5,000 live male births. So it is the commonest severe bleeding disorder. And actually, 1 in 5,000 births of male births is quite common. It's not the rarest thing. You'll certainly see a lot of haemophilia A during your time as a hematologist. Can you tell me a bit more about the inheritance?
So we said it was X-linked recessive.
Okay,
so
very good. Yeah.
the tendency is it's passed from mothers to sons. I think it's on the X. I think it's Q28. On the chromosome, which tends to be one of those that tends to like to mutate or break away from things. So, yeah. So that's what kind of I understand. Very basic genetics.
No, that's very good. Yeah, it's X-linked recessive, as you say. So this means it's going to be a condition that affects males because they only have one X chromosome. So if they inherit the dodgy chromosome with the mutation, then they will have the condition. And so what would you be focusing on in a family history?
So, I don't know. This is a question. Do carriers have any kind of mild symptoms?
Oh, that's a good question, David. That's a good question. I'll come back to that in a second. We'll talk about. So you've correctly identified that women are carriers. Can males be carriers?
I should. Oh, I shouldn't think. I mean, if they've only got one X chromosome, they're
exactly.
Yeah. Oh God, you're already coming.
Almost got you.
I know this is a mistake.
No, so you can't be a carrier as a male because if you've got the mutation, unless you've got, I guess, if you've got a condition where you've got 2 X chromosomes and a Y, I can't remember what that's called. I'm sure that's a condition. Is that Klinefelter's? Not sure.
Oh dear.
Sorry, listeners.
Now I'm embarrassing myself. Supposed to be doing my.
We're not geneticists. Don't listen to us. But basically,
Hader, cut this out.
Yeah. No, but basically, you as a female, you can be a carrier and you're most likely to be a carrier because you have one X chromosome that's affected and one X chromosome that's not affected. But as a male, you will be affected. And in terms of the family history, then, if it's X-linked, like any X-linked condition, you focus on any siblings, particularly any male siblings, and any maternal male relatives. So a maternal cousin, uncle, grandfather. And you asked about whether females as carriers can be affected. I'm going to turn that back to you, David. Do you think that they could be affected?
So I suppose. So I'm just trying to think. If it's a recessive thing, then if they have 2 alleles which are sort of rubbish, then yes. But
if they had 2, then they would.
They would be
carriers. They'd be a compound or they'd be affected with the disease. So if you've got one,
I don't know. It feels loaded, which means I'm going to say yes, but I can't base that in any clinical experience.
Okay, so basically, if you had a female with one X chromosome that's affected and one normal chromosome, you would think, okay, well, that's fine because a guy only has one X chromosome anyway, and so only has one factor VIII factory from one gene that they only ever get because it's an X-linked gene, right?
Yeah.
So, however, do you know anything about bar body formation?
Oh, I've never heard of that.
Okay,
Semaphore.
so basically, I'm going to enlighten you as to why the females
Oh,
are amazing. So women obviously have two X chromosomes, unlike men, but we don't need both X chromosomes. So one X chromosome gets completely inactivated during embryogenesis, and this is a process called lionization. I think it was named after a really cool lady called like Mary Lyon or something who won some sort of prize for
it's a
discovering.
strong name, that.
Yeah. But basically, lionization is where randomly one of your two X chromosomes in the woman is inactivated. It's like bundled up and it's not transcriptionally activated. And it forms what's called a bar body. And that's the
Okay.
inactive X chromosome. And this happens at random, right?
Yeah.
During embryogenesis. And fun fact, this is how tortoiseshell cats form. So you won't find a male. I don't know if this is fully correct. Again, disclaimer if this is incorrect, but this is how I've always remembered it.
Yeah, don't fact check us.
No, don't fact check this. But essentially, a tortoiseshell cat is one which is always female because the different coloured pigment genes are on the X chromosome, presumably. And so they randomly inactivate a different X chromosome in different cells, and that's what gives them the patchy coat, which is the tortoiseshell pattern.
Ah, nice.
So I don't think you can get a male tortoiseshell cat. Anyway, so this
There you go, folks. Not just a hematology podcast.
So basically, when you have this random process, usually because it's due to chance, you will still get your adequate amount. 50% of your cells in your body will be able to express factor VIII.
Yeah.
But because it's due to chance, there is always a risk that, it might be unequal and you might just happen in this one person to inactivate more X chromosomes that have the good gene on than X chromosomes that have the bad gene on, for example. And in that situation, they could end up having a sort of mild Haemophilia A type picture.
How interesting.
Yeah. And they say
Tortoiseshell
about 10% of female carriers are symptomatic. But it's relevant and important to diagnose and identify women that are carriers. One, because obviously it predicts a boy that's born from that woman having severe or, proper haemophilia A.
Mm-hmm.
But also, it's important because they can have slightly lower factor VIII levels because of this random process of lionization. And so when they undergo pregnancy, you need to, make sure you know what their factor VIII levels are and support them through that big hemostatic challenge of having a baby.
Yeah.
So that was a good question, David.
Yeah.
And we learned about...
Great answer.
Yeah, thank you.
We're very wholesome today. Well done, team.
Okay, so that's the family history. We're focusing on maternal male relatives. It's an X-linked recessive condition. In terms of the gene that's mutated, 50% of severe haemophilia A cases have a mutation in Intron 22. So this is a non-coding section of DNA, and we think it probably affects... So the non-coding DNA is usually kind of... it's the bit that's spliced out during the RNA formation, everything. But it probably, the mutation either introduces novel splice sites that then affects the coding parts of the DNA, or it might activate novel promoters or something like that.
Okay.
But Intron 22 of the X chromosome is the most common mutation. Do you have to have a family history to diagnose haemophilia A?
I don't think so. I think you can have, isn't it about a third of de novo mutations?
Yeah, very good. Yeah, exactly. So a third of cases, it's just a sporadic de novo mutation where the mother was never carrying a gene that she passed on. It just happened during meiosis. And we think that the mutations most commonly occur in those A domains in the structure of factor VIII because of that sequence homology. Because what happens is when the X and the Y pair together during meiosis, the spare X arm of the chromosome doesn't have a Y arm to pair with because it's pairing with a Y. Yep. And as a result, because the sequence is so similar in those three A1, A2, A3 domains, the arm can kind of like flip back on itself and stick to it, and kind of that's how we think it become mutated. I don't know if you can imagine that in your head.
I'm trying to sort of envisage it.
Like the X arm that cannot pair with anything basically flips up and binds with itself, and so then when it pulls apart, you get gene mutations. And we think that that's probably why most of the mutations are within that A domain area.
So you're saying it attaches to its own self as opposed to the other
chromosome
Yeah, okay.
from the male.
Oh, okay. Wow.
Yeah. And anyway, overall, all of these mutations that cause haemophilia A affect the amount of factor VIII that you can produce, basically.
Okay.
Okay. And it's really simple in haemophilia A. The amount of factor VIII that you have directly correlates with how much bleeding you're going to have and the severity of your disease.
Yeah.
Which is quite nice the way it's a disease that's become so complicated and exciting in terms of treatment. But fundamentally, even with genetic testing, the best way to classify and to, say whether you've got mild, moderate, or severe haemophilia is still based on your factor VIII levels.
That's quite nice.
Yeah, it is, isn't it?
Because it also can give you an empirical number as opposed to, I don't know, you are this amount. Yeah, mild
exactly.
Based on, I like that. I like that.
Yeah. And so basically the reason for your factor VIII level directly correlating with your bleeding is one, because you get failure of that thrombin burst that we were talking about. And so you get a primary hemostatic plug, but you then only get a really rubbishy secondary hemostatic plug with really friable fibrin, which is just not really adequate. And so it's really easily dislodged, and that can lead to rebleeding. And the other thing is that actually failure to activate enough thrombin and produce enough thrombin also means that you don't get your thrombin activated inhibitors of fibrinolysis, like the catchily named thrombin activatable fibrinolysis inhibitor, also known as the TAFI for short, which means that not only are you getting a really friable fibrin mesh in your secondary hemostatic plug, but you're also getting increased fibrinolysis because it's not getting the normal feedback loop. So both of those things mean that you get a bleeding disorder and a bleeding phenotype.
Sort of snowballs in the wrong direction.
Yeah. Okay, we'll stop there.
Grand.
Great. Okay, so now let's talk about presentation of haemophilia A. What sort of things might make you think, oh, could this person have haemophilia A?
Yeah, so the headline ones that you're always sort of taught is joint bleeds, deep muscle bleeds, prolonged post-operative bleeds.
Brilliant.
Those are the ones from the vignette, aren't they?
Exactly. Those are the ones that are kind of tell you there's a problem with secondary hemostasis rather than primary. Exactly. Very good. And do you know what the most common joints are?
Hips.
No.
Fired and missed. Please enlighten me. I always thought hips. I don't know why.
No, it's more ankle, knee, elbow. Think of the things that you can knock easily.
Okay.
You're less likely to knock your hip. It's like deep in your tissue.
Yeah.
So ankle, knee, and elbow. Elbows are usually associated more with a pulling injury. Your kid's not old enough for this yet, but when you're like yanking them away from something that they're doing, like, come on, we're leaving the park. That can give you an elbow. And then most common deep muscles to get bleeds.
Oh no!
You gonna shoot again?
I'm gonna shoot it. Quadriceps.
No, the iliopsoas muscles. So you get an iliopsoas bleed, calf muscle, and forearm muscle.
So basically, around the joints you've just mentioned.
Yeah, I guess so. Yeah.
I don't know where I've picked this nugget up. That's clearly wrong, and it's so.
Yeah, everybody forget hips. Okay, it's things that you can knock easily.
Ignore the stupid SHO. He's just here to make up the numbers.
So yeah, and basically bleeds are often spontaneous or with minimal trauma. So classically in a severe haemophilia A, when do you think you're going to start getting bleeds?
So I imagine in young children who are getting up and walking around and bumping into things for the first time.
Yeah, exactly. So when they start to learn to walk, so from sort of whenever they learn to walk, 10 months onwards sort of thing.
In my daughter's case, probably not for a little while.
Okay, fair enough. Sebi was 10 months. So from then, learning to walk, standing up and things like that, that's when they can start getting bleeds into the knee, for example. And so we're not talking about adults for a first presentation of a severe haemophilia A. And I think that's really important to understand. If you're seeing a 10-year-old in A&E with a swollen knee joint, by all means think about haemophilia A. In fact, you should think about haemophilia A, but it's not going to be, I can tell you now, if that's their first presentation, it's not going to be severe haemophilia A. And obviously, the older you get, before you're at your first presentation, the less severe the haemophilia A is likely to be. And it can be newborn babies with a bit of bruising, or they notice more bruising around the vitamin K or injection sites for the vaccines.
Yeah.
But usually it's when they become mobile that you start to notice like joint bleeds. And muscle bleeds can be really hard to spot, particularly like a chubby toddler, when their arms are all, they've got all those lovely
Yeah. Yeah.
fatty arms and legs, but it can make detecting muscle bleeds quite difficult. So it's things like child not using their limb, or the child's in pain, or they're just off, they're not themselves. It's not usually as obvious as like 1 year old starts walking and comes in with big swollen knee. Do you know what I mean?
Yeah.
And do you know why they tend to bleed into joints, or what people think, what's postulated as the potential reason for joint bleeds as opposed to other places?
I'm trying to think. I don't really
Yeah,
know. I guess
no.
just just think the articulation points, but I don't know why that would make it more likely.
Yeah. I mean, there's a theory that it's due to there being lower levels of expression of tissue factor within the synovial tissue. And so,
Oh,
therefore, they're just more vulnerable to bleeds due to that. And then, obviously, once you get a bleed, and you're at risk of getting recurrent bleeds because the blood containing the iron is very irritating and very pro-inflammatory and pro-angiogenic, and then you get new blood vessel formation within the joint, causing a target joint, and it becomes a vicious cycle of hypertrophy and hypervascularity. And that's what can lead ultimately to the deformities and the comorbidity in haemophilia A if it's not treated. Okay, so we've talked about joint and muscle bleeds. Any other kind of bleeds that might kind of raise your alarm bells?
um. So I guess non-petechial. I don't know if that's even a thing. I guess
Yeah.
yeah, things that don't look like like a petechial dotty kind of bleed.
Yeah,
Um, I
exactly.
guess
So
that's what would get my alarm bells ringing. I don't have anything specific to offer, I guess.
no, you're right. It's basically any other bleeding history in an adult. For a mild to moderate in an adult, it can be from bleeding post-op, or something like that, where you just think, actually, we need to think about mild or moderate haemophilia A here. But anyone with severe haemophilia A, as we said, is more likely to be diagnosed and present before the age of 2. And anyone born in the UK over the age of 4, we say will have already been diagnosed with severe haemophilia A if they do have it. So yes, any bleeding diathesis, which sounds like a secondary hemostatic problem, you would think about haemophilia A and you would test factor VIII. Very good. But then there's some other thing in children that you might also raise your alarm bells. Can you think of any other sort of critical bleeding?
Are we talking about sort of non-accidental
So
bleeding?
there's a big crossover with that, and I'm glad you mentioned that, and we will come back to that,
Or
because
we're
it's a
talking
very good big
brain
nature
bleeds?
paper. Brain bleeds, exactly.
Okay.
Intracranial hemorrhage is the other situation in which, in children, you must think about haemophilia A. And as you said, there's going to be a crossover with non-accidental injury. Um, but severe haemophilia A can cause a spontaneous intracranial hemorrhage with no trauma. It's worth bearing in mind that a mild to moderate haemophilia A, you would need some trauma to cause an intracranial hemorrhage, but that's not necessarily non-accidental trauma. I mean, my kid's hitting his head like all the time. They just do that. So an unexplained intracranial hemorrhage in a baby or a child would definitely need contact with hematology from the pediatricians. And also, sadly, at birth, so birth trauma in a
Mm.
baby that you didn't know the mother was a carrier, or a de-novo mutation, so you weren't expecting a haemophilia A risk, and so you didn't take all the precautions that we would normally take when expecting a haemophilia baby. So things like no forceps, no von twos, they can be born with a major intracranial hemorrhage. And just
Gosh, I didn't
remember,
even think about that.
yeah,
Yeah.
and just remember also that like it's really important that hematologists are involved early with an intracranial hemorrhage in a child, because it's important to get those tests off, not to delay treatment, but to make sure you get those tests off before they start getting given cryo and factor. Otherwise, you might mask the factor VIII and make it look like it's not hemophilia when it is. So
Yeah.
it's just really important to get the hematologist involved early, by
I
the
imagine that's
pediatrician.
something that you would hope in bigger trusts that there would be a pediatric hematologist of some
Yeah,
description, but I imagine in
exactly.
smaller trusts and DGHs and
Exactly.
stuff, it's
I
it's you. Yeah.
Exactly. I think it's probably quite protocol driven, and I haven't really had any phone calls about it, which makes me think that they probably phone a pediatric hematologist, so they probably
Yeah.
phone Bristol for us. But you mentioned non-accidental injury, and um, obviously, whenever you've got a non-accidental injury case in peds where you think that might be non-accidental injury, you do need to make sure that you have ruled out a bleeding disorder, because otherwise,
Mm.
that would be bad. So they suggest that the BSH have done a paper on this, and a guideline, and they suggest that bruising in a pre-mobile child, or an unusual pattern of bleeding or out of proportion to that of the mechanism described, or any critical site bleeding, which they describe as being intracranial hemorrhage, GI, retinal, intraspinal bleeding, and hemarthrosis, all need investigation, as well as also if there's a family history that's suggestive of a bleeding disorder. And so they say the first line investigations are to do a full blood count, mainly to rule out a severe thrombocytopenia, a clotting screen, mainly to rule out any severe haemophilia A or B, and then a blood film as well, to look for any obvious platelet disorders. And if all of those are normal and you've not got any other red flags, then you can stop at that point. But if the parents are potentially consanguous, or if you have, bleeding at a critical site, or there's suspicion from the history that there's an inherited coagulopathy, then you need to go on and do second line investigations, which are essentially assaying all of your factors, doing a one-stage anachromogenic assay, a von Willebrand's disease screen, and also some sort of platelet function assessment, as long as the child is over the age of 12 months old. So it's just good to think about that. And unless you're going to do pediatric hematology, you're probably not going to get asked about it. But I think an awareness of it and the role that hematology plays in non-accidental injury is really important.
Yeah. There will be a point when somebody asks you. At least
Exactly.
knowing that that guideline exists is probably the most helpful
Yeah,
thing that you
exactly,
can know.
David. Yeah. So we've said that haemophilia A presents mainly in childhood, and that more mild conditions can present later on in life. That it presents with spontaneous joint and muscle bleeds characteristically, or any sort of bleeding, like post-op, for example, and intracranial hemorrhage makes us think about it as well. But the other thing from talking to one of my friends who's a pediatrician is that she says that it's not always this classic kind of joint bleed that is how haemophilia A can present, and that often it's this sort of rebleeding history. And I've been reading about this since, and it seems to be common knowledge in pediatrics that it's this classic pattern of on-off bleeding, which makes you think about haemophilia A, especially like a cut in the mouth, like if you've bitten your tongue or there's a bit of a frenulum tear, that the child can stop and start bleeding from this site recurrently for sometimes weeks without anyone really noticing, and can become quite anemic from it. And it's, I guess, because, they form a clot, but it's not strong enough, and so it washes off, and then they bleed again, and then they clot again. And so actually rebleeding pattern, particularly on mucosal surfaces, is another way in which haemophilia A can present, particularly in children.
Wow.
I thought that was
Pres-
interesting.
yeah, presenting with anemia. Can you imagine?
I know, from
That's
such a
quite the
small thing in the mouth. Yeah.
yeah.
Mm. Okay, so that's how it presents. Should we talk a bit about diagnosis? Do you have any
Yep.
cutoffs in your head for factor VIII levels?
Um no, probably not. So from what I understand, that the numbers are, it's based on, isn't it, factor VIII activity? Is that the right
Yep,
term?
yep,
And I think severe is less than 1%, and then moderate's up to 5, and then mild's considerably more than that. I don't have an exact number for that.
yeah,
So
exactly.
those
So
are the numbers that I've got in my head.
yeah, so essentially, a factor VIII level of less than 40 means you've got some form of haemophilia A. So that's your first
Yeah.
number to have in your
So
head,
40.
40.
Yeah.
And it's annoying because von Willebrand's is different. So you have to have multiple different numbers in your head,
Of course you do.
which is frustrating. But so it's less than 40, okay?
Yeah.
And when I'm saying 40, I'm working in units of international units per deciliter. I know we're encouraged to use international units per milliliter, but it's just not as nice to think about it. So you need to be familiar with both. But using deciliter allows you to almost think about it like a percentage. And I
Yeah,
don't know if it is a percentage, and we've talked about this before, haven't we?
yeah,
But I think about it of like, okay, you've got haemophilia A if you've got less than 40% essentially of your factor VIII. And we know that like 50% is adequate for most things, including
yeah.
like major surgery. So less than 40. So mild haemophilia is anything from 6 to 40 international units per deciliter. And they'll get severe bleeding with major trauma or surgery, but probably not much else. So those are like your adults presenting. Then you've got moderate, which is anything from 1 to 5. And 1 to 5 is moderate haemophilia, and that is occasional spontaneous bleeding, prolonged bleeding with minor trauma and surgery. And then you've got your severe haemophilia, which is going to present before the age of 4, is going to be diagnosed in the UK. And that's less than 1. So you have less than 1% factor VIII, which is why you get severe bleeding, you get spontaneous bleeding into joints and muscles and intracranial hemorrhage. So that's your cutoffs, and it's as simple as that. You just basically have to memorize it.
Yeah.
So what investigations do you think? You've got somebody in the H&T clinic. They come in, you've done their bleeding history. It sounds like a secondary hemostatic issue. The ISTH BAT score you've gone through, it's raised. They're a boy, and you now want to do some further investigation. So you've done your bleeding history and your family history. Check. What next? What blood done?
So I probably want to rule out other things. So
Okay.
I'd like to do a full blood count, make sure their
Okay.
platelets are normal.
Good. Yeah.
I would do a PT and an APTT.
Okay. And what are you expecting to see?
Normal PT, prolonged APTT,
Yeah. Great. That's
which
really
I
good.
hope should correct with a mixing study.
Very good. Yeah. So typically, just to give you some ideas of numbers in your head, a severe haemophilia A patient's APTT is usually above 100.
Okay.
A moderate is between like 60 and 100, and
Yeah.
mild, it might not even prolong it, or it might
Okay.
prolong it only a small amount. And yes, then if it is if it is haemophilia A, it will correct, as you say, because it's not an inhibitor. It's just that they need more factor. Good. And then what other tests are you going to do, David?
Um, I would do some assays.
Okay.
So I do my factor VIII assay.
Yeah.
Probably we'll do a von Willebrand's assay as well to make sure it's not a von Willebrand problem driving
Okay.
my factor VIII.
Yeah.
And just for completeness, I'll do a factor IX as well, just to get rule out haemophilia B.
Yeah, exactly. If you're gonna assay factor VIII, you might as well do 8, 9, and 11 and 12, because you're investigating the prolonged, if it's an isolated prolonged APTT, you might as
Yeah.
well test all of those factors that can cause a prolonged APTT. Otherwise, if your factor VIII comes back normal, you're gonna have to go get more blood, do
Yeah,
another
yeah, yeah.
test. So we do 8,
That's how
9.
us blokes do it. Actually,
Is it?
we'll bleed them 4
Cover all
times.
bases. Oh, is that
Yeah,
what you do? Oh, right,
yeah,
okay.
yeah.
Very
Yeah,
efficient.
yeah. That's us.
So factor VIII, factor IX, factor 11, and factor 12 is what I would assay. And you need to do a 1-stage and a 2-stage chromogenic assay, because if you remember when we talked about factor assays, there's this discrepancy that you can get between 1 and 2-stage. And essentially, the 2-stage or chromogenic assay is generally better at detecting most haemophilia A. But we always start with the 1-stage because it's cheap and easy. And then a von Willebrand's disease screen, as you said. So that's measuring the von Willebrand antigen and also the activity of von Willebrand, which is the Rickoff, which we'll come back to another time. Any other tests you'd want to do?
Um, can I then do some kind of genetic testing?
Yeah, good. So the UK HCDO, which is the UK Haemophilia Centre for Doctors Organisation, I think that's what it stands for, but it's like the haemophilia guidelines, and they're really good. They do teaching every Friday before work as well, I think once a month, which is well worth tuning into, by the way. But that society, they recommend that everyone with a new diagnosis of haemophilia A and B have mutational analysis. You might ask, well, why? Why do we need to do mutational analysis? If we know their factor VIII level is low and it's not von Willebrand's disease, then what's the point in doing a fancy genetic test?
Is it because we're hematologists?
Well, it is because we're hematologists and we're obviously always interested in the genetics underlying the condition. You are right. But actually, it's more fundamental than that. It's because it can help inform the likelihood of an inhibitor formation by knowing how different your factor VIII looks based on the mutation that it has compared to
Okay.
normal. Okay.
Interesting.
And also, it's essential for your female carriers because how are you going to identify a female carrier for a boy that's born with haemophilia that you've diagnosed? Okay. You need, because she may well have normal factor VIII levels, as
Yeah,
we've
yeah.
said. And so then you can't prove that she's a carrier. And also, by knowing what genetic mutation he's got, you can then test her for that genetic mutation, and then it allows sort of, screening and tracing through the family.
Yeah.
So there is a reason for it, but it doesn't really influence practice, if that makes sense. Except for
Yeah.
the carrier women, if she's planning to have more babies, for example, or whether it was a de-novo mutation. And then also, some labs would also do upfront a final test, which is designed to rule out that von Willebrand type 2N that we talked about earlier, where there's a problem with the von Willebrand factor being able to bind factor VIII. And so you essentially get low factor VIII levels, which mimics clinically in some ways a mild haemophilia A. But actually, the issue is with the von Willebrand factor's ability to bind factor VIII, not the factor VIII itself. And that does make a difference as to whether you diagnose someone with mild haemophilia A versus type 2N von Willebrand's disease, because you're going to be replacing different things to support their coagulation around an operation or if they're bleeding. And so the test you do there is a von Willebrand factor VIII binding assay. And it's essentially where you're looking at how well the patient's von Willebrand is able to bind factor VIII. And we'll go into that in more detail when we talk about von Willebrands as a separate topic. But that is probably the final test that I would do. So I'd do a bleeding history and a family history, a full blood count, a blood film, a clotting screen, mixing studies. Then I'd assay the intrinsic factors with a 1 and 2 stage chromogenic assay, a von Willebrand's disease screen, a mutational analysis to identify the gene to see whether the mother is a carrier. And then I would do a von Willebrand factor VIII binding assay.
Lovely.
And something else just to say is that sometimes people will then also assay factor V, because factor V and factor VIII can be co-inherited as a co-inherited factor deficiency, and that's autosomal recessive. So if your X-linked pattern is not really working out well when you're drawing the family tree, then always think about that, because you don't want to think, oh great, I've replaced their factor VIII, but actually they're still factor V deficient and so they still bleed.
Yeah. Interesting.
Yeah, so those would be the investigations that I would do.
Just a quick question. You're
Yeah.
talking about the sort of the binding to von Willebrand's. Is there a sort of form of factor VIII problem where those C subunits that you said bind the von Willebrand's are the issue?
Yes, and it's called pseudo von Willebrand's disease.
Okay.
So you've got platelet type and you've got, oh no, hang on. Am I telling you the right thing here?
This feels like when the consultant says, "Why don't you go and find this out yourself and do a case report next week?"
Yeah, I'm just thinking. So, I don't know if there is, David, but there must be. But I haven't heard of it.
Because I was just thinking, you were talking about the binding. You would then have to replace the factor VIII, wouldn't you, instead of von Willebrand, which is kind of the opposite of what we're discussing.
I don't think so.
Okay.
Not as a common thing. I was getting confused with a different type of von Willebrand's 2B, which you can get as a pseudo von Willebrand's platelet type versus actual von Willebrand's. But I'm not going to say
that's another episode,
not
folks.
to confuse you. Yeah, that's for von Willebrand's disease discussion.
Okay.
But no, I mean, hypothetically, you would think yes, there could be. But would it really make any difference? Because it's really that the factor VIII needs the von Willebrand's to prolong its half-life rather than the von Willebrand's needs factor VIII to prolong its half-life. Do you get what I mean?
Yeah.
So I'm not sure it would matter.
It wouldn't affect that assay, would it?
No. I think if you had mutations that don't affect the ability of factor VIII to work as a clotting factor, as a co-factor, then I don't think it would make any difference.
It would just have a shorter half-life.
It would just have a shorter half-life.
Yeah.
Yeah.
It should do all those
Very
other
interesting
things.
question.
The thrombin burst should be fine. And their subsequent sort of anti-fibrinolysis stuff should be fine.
Exactly.
It's just,
But it's great that you're thinking about it.
I'm trying to get these subunits in my head somehow.
Yeah, you've caught me out there because I don't know the answer. So
I will stick this one
everyone
in my
at home
fridge.
can go and read that when they finish their car journey and then email us with the answer. I'm sure
that would be joyful. Interacting with the community.
Right, so what's the biggest cause of death in haemophilia? Just to finish on a jolly topic.
Yeah, okay. Thanks for dragging this back in. What? I don't know now.
Intracranial hemorrhage.
Okay.
Okay, so that's still the thing we worry about. And when we talk about prophylaxis, it's one of the indications for putting somebody on prophylaxis.
Okay.
And the biggest cause of disability is obviously target joint formation, which we've talked about. But now there is actually a normal life expectancy for a child born in the UK with haemophilia, which is great.
Yeah. Awesome.
So
that's a nicer note to finish on.
Exactly. Last thing before you're not quite able to get away yet. Female. You love haemophilia, David. We've only just got started. Females. Do you think a female could have haemophilia A? In what situations? Just because it tests your kind of understanding as well. In what situations could you have a female with actual haemophilia A that's not just a carrier with, an unlucky degree of lionization of her good chromosome?
Could it be if they've got an antibody against a normal or an anticoagulant?
We're not talking about acquired haemophilia right now.
Okay.
But yes, I guess if you did have a female that you thought might have haemophilia A, always think about acquired haemophilia A, but that's a separate podcast and that's an autoimmune condition.
I can't put it together.
That's fine. So you've got Turners, where they've only got one X chromosome, but they are female. You've got complete androgen insensitivity, where they phenotypically are female, but genetically are XY. There's a condition called where you get extreme lionization. So you get a mutation in the ZIS gene, which controls methylation of the X chromosome. So I guess you just inactivate too many good X chromosomes. And then finally, you can also get, you could in a consanguous situation get just unlucky enough to inherit two bad X chromosomes, both with either the same genetic mutation or a compound heterozygous, where you've got two different mutations, one in each of the X chromosomes. So that's how you could get that.
Yeah, don't do that, kids.
No. Okay, well, that's it. So that's all I wanted to say, really. I don't know if you have any other questions about sort of...
No, I have to say this has been very enlightening, and actually I can see why you're so enthused by it.
Yeah, it's fun doing the clinical stuff. It's only going to get better when we start talking about the treatment. So should we just do our three...
I'm so excited.
Shall we just do our three take-home messages? Firstly, that the presenting features of haemophilia A are joint and muscle bleeds, often spontaneous and severe disease.
Not hip.
Not hip. Very good. So joints and muscles, intracranial hemorrhage, any abnormal prolonged bleeding after surgery, for example, or trauma or a cut or anything, and this rebleeding in mucosal surfaces in children. Secondly, that if you're going to have severe haemophilia A, it will present by the age of 2 and certainly be diagnosed by the age of 4 in the UK. And 3, your cutoff in your head is a Factor VIII level of 40, and your severity is completely determined by your Factor VIII levels, in which severe haemophilia A, you have less than 1 IU per DL. And I think we'll end there.
Yeah, great.
Great. Okay, well, I'll see you next week, David.
I'm looking forward to it.
See you later. Bye. Thanks again for listening to Basics to Brilliance Haematology podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.